Okay. This patient has urolithiasis, 5 millimeter ureteral stone on CT scan that has been causing severe flank pain, nausea, vomiting, and hematuria for the past day. Now she has developed fever and chills and has postoperative angle tenderness on examination. These findings are concerning for urinary tract infection, pyelonephritis, and possible sepsis. Urolithiasis accompanied by infection require urgent urology consultation because it can rapidly progress to severe sepsis and shock. In addition to typical management with fluid resuscitation and pain control and antiemetics, and affected patients usually require IV antibiotic and urinary tract decompression, ureteral stenting, percutaneous nephrostomy. Other indication for urgent urology consultation in urolithiasis is acute kidney injury, refractory pain or vomiting, and anuria, which indicates complete obstruction. Okay. This patient with blunt abdominal trauma has suprapubic tenderness, hematuria, intraperitoneal free fluid on fast. This presentation is most concerning for intraperitoneal bladder rupture and should be evaluated with cystography. Blunt lower abdominal trauma. Blunt lower abdominal trauma can abruptly increase intravesical pressure and rupture the bladder at its weakest part. Peritonitis often does not develop acutely because urine is typically sterile. Instead, the most common clinical findings of bladder rupture are hematuria, suprapubic tenderness, difficulty voiding, associated pelvic fracture, widening of the pubic symphysis, retrograde cystography, in which bladder is passively filled via Foley's catheter, retrograde cystography, in which bladder is filled via Foley's catheter with water-soluble contrast, and then imaged CT scan can confirm the diagnosis. Surgical repair is typically required for intraperitoneal rupture because continued efflux of urine through the defect prevents spontaneous healing. Okay. In the triage of bad patients, in the triage of bad patients, diagnostic peritoneal lavage may be used to evaluate hemodynamically unstable systolic blood pressure less than 90, patients with intra-abdominal hemorrhage which would be necessitated immediate laparotomy. This patient is hemodynamically stable and can tolerate further testing. CT scan with cystography to determine the source of intraperitoneal free fluid urine. Yes, hemodynamically unstable if it is peritonitis laparotomy. Hemodynamically unstable if no peritonitis, free fluid on fast laparotomy. If it is inconclusive, consider CTAP. Consider CTAP, CT scan of the abdomen and pelvis after resuscitation or diagnostic peritoneal lavage. Evaluate for other sources of hemorrhage. If hemodynamically stable, peritonitis present, laparotomy. If peritonitis is absent, free fluid on fast, positive CTAP, that means CT scan of the abdomen and pelvis, free fluid on fast, positive, then CTAP. If it is inconclusive, consider CTAP or serial abdominal examination based on suspicion for intra-abdominal injury. Okay, this patient has fever without a source, acute otitis media bronchiolitis. Most children with fever have a viral illness, but occult viral infection, urinary tract infection, bacteremia, pneumonia must be considered in patients or unimmunized children due to an increased risk of in this group due to an increased risk in this group. The most common occult infection is a UTI, female children, uncircumscribed male infant, and those with urologic abnormality, vesicoureteral reflux are at highest risk. In contrast to UTI symptoms, in contrast to UTI symptoms in older children, dysuria, suprapubic pain, the presentation of UTI in infants is non-specific and can include fever, fuzziness, poor feeding, fever, fuzziness, poor feeding. Gastrointestinal symptoms, vomiting may occur. Evaluation for an occult UTI is urinalysis and urine culture. Straight catheterization is preferred for obtaining sterile sample in patients who are not toilet trained. Pyuria on urinalysis and bacteriuria more than 50,000 colony forming unit per ml from a catheterized sample on urine catheterized sample on urine culture confirm the diagnosis. Treatment is antibiotic cephalosporin to prevent pyelonephritis and scarring, renal scarring. Yes, these young these young patients with non-productive cough lymphadenopathy. This young patient with non-productive cough lymphadenopathy rash and symptoms of hypercalcemia, constipation, fatigue, likely has sarcoidosis. Sarcoidosis has multi-system granulomatous disorder, skin involvement. Up to 25% of the patient as seen in this patient has erythema nodosum violaceous indurated nodule on the shin and a papillary sarcoid, multiple scattered papillary lesion impairments in calcium homeostasis. In sarcoidosis are primarily impairment in calcium homeostasis in sarcoidosis are primarily driven by abnormal activity abnormal activity of 1-alpha hydroxylase, which normally converts abnormal activity of 1-alpha hydroxylase, which normally converts calcidiol to calcitriol only in kidney. In sarcoidosis, abnormal external calcitriol conversion into the activated macrophage in the lymph node lungs, causing a cascade effect. Serum calcitriol increases, which stimulates intestinal calcium absorption, causing hypercalcemia. PTH decreases due to negative feedback by hypercalcemia. PTH decreases due to negative feedback by hypercalcemia and increased calcitriol. And renal calcium reabsorption due to low PTH and Due to low PTH, serum calcium is high, renal excretion increases. Hypercalcemia and sarcoidosis result from abnormal calcitriol production, and therefore it is PTH dependent. PTH dependent hypercalcemia involves failed negative feedback, such PTH is inappropriately unsuppressed uh, despite a high calcitriol and hypercalcemia patient. Primary hyperthyroidism is most common cause, and urinary calcium level in hyperparathyroidism can be increased or normal depending on the severity of hypercalcemia. Cardiovascular eh, cardiovascular disease is the most common cause of death in patients with cardiovascular disease is the most common cause of death in patients with end-stage renal disease, accounting for approximately 50% deaths even in younger patients. Traditional cardiovascular risk factors including hypertension, dyslipidemia, diabetes mellitus, ventricular hypertrophy, sedentary lifestyle, and advanced disease. Average age of dialysis initiation more than 60 years are highly prevalent in patients on dialysis. In chronic CKD is the most important risk factor. CVD due to factors related to renal dysfunction and/or renal replacement therapy, including the following metabolic abnormalities: hyperphosphatemia, increased calcium load, vitamin D supplementation, and arterial calcification, coronary artery stiffening and narrowing, left ventricular hypertrophy, and diastolic dysfunction. Urinary acid renal urinary acid renal uremia and renal replacement therapy cause oxidative stress, resulting in accelerated atherogenesis and inhibition of the nitric oxide, and anemia in patients with ESRD is a risk factor for CBD and is associated with worse outcome in acute coronary syndrome. CVD also accounts for significant morbidity in patients with ESRD, peripheral artery disease, extensive vascular calcification, and poor arterial supply can lead to non-healing foot ulcer and result in amputation because of the increased morbidity and mortality. Patients with ESRD require aggressive management, both traditional and renal specific cardiovascular risk factors. Yes, patients with ESRD are at increased risk of psychiatric condition, prevalence up to 70%, especially depression and anxiety. The Incidence of death by suicide is higher than general population, but much lower than death of CVD. The risk of venous thromboembolism. The risk of venous thromboembolism in patients with ESRD is quite uh, ESRD is twice that for the general population, but death attributable to CVD is much higher. Although some elderly patients with poor functional status and quality of life may withdraw from dialysis, this is uncommon outcome in 50-year-old boy. Stone is there is no fever and stone is less than 5 millimeter. So discharge that. This patient this patient has acute flank pain and nausea due to urolithiasis, and CT scan reveals 4 millimeter stone. There are no signs of urinary there are no signs of urinary infection. There are no signs of urinary infection, fever, pyorrhea, renal function is normal, and pain and nausea are well controlled following administration of analgesic and antiemetic. This presentation is consistent with an uncomplicated ureteral stone can be managed conservatively at home. Most ureteral stone less than 5 millimeter in diameter pass spontaneously. Oral analgesic NSAIDs are typically prescribed, and increased oral intake more than 2 to 2.5 liter per day is advised. Mm, mm, Most ureteral stone less than 5 millimeter in diameter pass spontaneously. Oral analgesic NSAIDs are typically prescribed, and increase oral intake more than 2 to 2.5 liter per day and is advised to ensure flow of dilute urine. In addition, patients are instructed to strain their urine so that a stone can be captured for composition analysis, composition effects, recommendation for future stone prevention. For larger stone more than 5 to less than 10 millimeter, an alpha blocker may help to facilitate uh, passage. If stone is more than 10 millimeter, are unlikely more than 10 millimeter unlikely to pass spontaneously may warrant outpatient urologic evaluation to consider additional intervention leadership. Okay. Vesico recurrent UTI in infants and children are a serious problem as they often involve the kidney and signify a congenital urinary tract abnormality. One of the most abnormalities is primary viewer. Normal urine should have unidirectional flow from the kidney. Normal urine should have unidirectional flow from the kidneys, ureter, bladder, out of urethra. Patients with severe VVR have urinary reflux from the bladder into the kidney, and the regurgitated urine causes dilatation of the ureter, hydroureter, and kidneys hydronephrosis. To definitive diagnosis of the vesicoureteral reflux is made by contrast voiding cystourethrogram. Contrast voiding cystourethrogram. Renal ultrasound is performed to screen for hydronephrosis. Recurrent or chronic pyelonephritis can lead to blunting of the calyces, calyceal clubbing, focal, parenchymal scarring, renal scintigraphy with dimercaptosuccinic acid. Renal scintigraphy with dimercaptosuccinic acid is preferred modality for long-term evolution for renal scarring. Renal function should be followed by serial creatinine. Patient should be monitored closely for complication of chronic renal insufficiency such as hypertension and anemia. This patient has postoperative this patient has postoperative unilateral back pain. This patient has postoperative unilateral back pain, nausea with vomiting, postoperative ankle tenderness are most likely due to hydronephrosis from ureteral injury, gynecologic surgery, particularly hysterectomy. Gynecologic surgery, particularly hysterectomy, has the highest risk for iatrogenic ureteral injury due to proximity of the ureters. Due to the proximity of the ureters to the pelvic organ, particularly the uterine artery, risk of uh, ureteral injury increases in patients with obesity, distorted pelvic architecture from malignancy, as seen in this patient, or prior pelvic surgery, cesarean delivery. Ureteral injury most ureteral injury most commonly occurs due to accidental suturing of the ureter during uterine artery ligation, or uh, or vaginal calf closure, which can cause partial or complete ureteral obstruction. Patients with ureteral obstruction develop hydronephrosis. However, symptoms can be masked initially by postoperative pain medication. Because only one ureter is affected, patients typically have normal renal function, normal creatinine and urinalysis. However, irreversible renal damage can occur if obstruction is untreated. Diagnosis can be made by renal ultrasound. Treatment is surgical correction of the obstruction. Okay. Okay. This patient has fever, tinnitus, sinusitis, irritation after medication overdose scenario, highly salicylate intoxication due to aspirin, due that her father takes coronary artery disease. Acute cellular toxicity causes a mixed acid base disorder. Primary respiratory alkalosis develops shortly after ingestion because salicylates stimulates the medullary respiratory center. Salicylates directly stimulates the medullary respiratory center and resulting in increased ventilation and low PaCO2, low PaCO2 or less than 40. Primary anaerobic metabolic acidosis develop after several hours because toxic salicylates inhibit oxidative phosphorylation. This results in accumulation of unmeasured organic gas ketoacid lactate in the blood, causes low serum bicarbonate increase and anemia. This the mixed disturbance can be diagnosed by inappropriate compensation of the metabolic disturbance, of the using Winter's formula bicarbonate for PCO2 29 for 14 into 1.5 plus it plus minus 2. So the actual PCO2 is 23, is lower and indicates concomitant respiratory alkalosis. Working in other direction, there should be minimal metabolic compensation for respiratory alkalosis, minimal decrease in bicarbonate. In the acute setting, the significantly decreased serum bicarbonate and of 14 milliequivalent indicates a concomitant primary metabolic acidosis. So, salicylate can cause mm, both like a metabolic acidosis and respiratory alkalosis. Yes. So as it caused the mixed one, so in initially it caused respiratory alkalosis, then later on it causes metabolic acidosis like acute and chronic. Okay, so in acute pH is alkalotic manner and PCO2 is low and bicarbonate is also low. Okay, low pH 7.35 with low bicarbonate and low PaCO2 is consistent with primary metabolic acidosis with respiratory compensation. PaCO2 is 27 millimeter of mercury is appropriate compensation for bicarbonate 12 into 1.5 plus 8 plus minus 2, indicating the absence of additional primary disturbance. The salicylates clinically results the acute salicylate toxicity presents with isolated primary metabolic acidosis unless there is co-ingestion of respiratory depressant or opioid that prevents the primary increase in the respiratory drive. And low pH with high PaCO2 is consistent with respiratory acidosis. Minimal increase in serum bicarbonate, often minimal increase in serum bicarbonate above 24. Minimal metabolic compensation indicates respiratory acidosis is acute. Okay. Okay, normal urine output in a neonate. Normal urine output in a neonate defined as one or more than one void per day of life. This infant has had only one wet diaper in the last 48 hours. Only one wet diaper in the last 48 hours of life. Therefore, has oliguria from the neonatal acute kidney injury. All neonates with oliguria further evaluation. Require further evaluation with the following history of history and physical examination to evaluate for possible risk factor nephrotoxin, his family history, renal anomaly, nephrotoxin family history, renal anomaly, and volume status, volume overload, renal and bladder ultrasound, renal and bladder ultrasound, which documents the number, shape, and size of the kidney and detects vascular abnormalities, or congenital anomalies, are particularly concerning in this patient with no prenatal care. An IV fluid bolus is often used when hypovolemia, excessive weight loss, dry lips from prerenal disease is the suspected case of neonatal oliguria. However, establishing normal renal anatomy is required first because in neonates any obstructive neuropathy, sorry, where I am, an IV fluid. Okay, I think that renal and bladder ultrasound. That's it to find out the yes. Avoiding cystourethrogram provides detailed imaging of the distal urinary tract and can elucidate the reasons for pathology seen on renal and bladder ultrasound. Reflux are leading to hydronephrosis is performed only if ultrasound is abnormal because the procedure is invasive and involves radiation. Okay, this patient has likely nephrotic syndrome. in association with the joint pain and characteristics hand deformity, ulnar deviation, swan neck deformity, and nodule. This presentation suggests rheumatoid arthritis complicated by A amyloid. Serum amyloid A protein is an acute phase reactant, therefore AA amyloids. AA amyloidosis AA amyloidosis often develops in the setting of chronic inflammation, osteomyelitis, rheumatological disease. Long-standing RA is the most common cause. Patients with untreated RA are particularly susceptible. Renal disease with proteinuria and or nephrosis. Skin involvement can lead to thickening or easy bruising, chemosis, cardiomyopathy, gastrointestinal hepatomegaly, dysmotility, and neurologic peripheral neuropathy, dementia, stroke disease may occur. Lab studies can show elevated inflammatory markers, ESR, normocytic anemia due to chronic inflammation. The diagnosis is confirmed with the process of amyloid or tissue biopsy. Fat PET renal biopsy can be considered. If fat PET biopsy is non-diagnostic, history demonstrates amyloid with Congo red green birefringence under polarized light. Yes. Is it AKI? There is no history of cancer, isn't it? She has also a muscle cramp for 3 days. Why there is muscle cramp? Uh, cell breakdown, hyperkalemia, hypercalcemia. Where is the phosphate? No hyperphosphatemia. BUN by creatinine ratio. It yes, and there is crackles. Urine sodium is high, normal size. No evidence of hydronephrosis. I I think that it is pre-renal AKI. Maybe. uh, there is a chart like like urine sodium. Mm, urine sodium. Urine sodium isn't it high? Yes, I think that high. Less than 25 and it's AKI. Then think about. Yes, it's not pre-renal. It's renal AKI. It's a renal AKI, tubular necrosis, where BUN by creatinine ratio less than 15 or 20, like normal, and urine sodium is high, FeNA is more than 2, urine osmolarity is 300, and urine specific gravity is low. There is muddy brown gas. This patient presents with several features of significant AKI. This patient presents with several features of significant AKI, including a rapid rise in creatinine, hyperkalemia, metabolic acidosis, bicarbonate less than 18, volume overload crackles, edema, systemic manifestations of uremia, weakness, nausea. AKI is often categorized as follows. Prerenal characterized by low urine sodium. Prerenal characterized by low urine sodium less than 20. Prerenal characterized by low urine sodium less than 20 and elevated BUN by creatinine ratio more than 20 due to passive urea reabsorption. Postrenal classically causing hydronephrosis on ultrasound and intrinsic characterized by high urine sodium, typically more than 40, FeNA more than 2% due to tubular damage, limiting resorptive capacity. In contrast to prerenal AKI, BUN by creatinine ratio tends to be normal, 10 to 15, 10 to 15 is to 1. This patient ultrasound findings and chemistry results, high urine sodium, BUN more 10 is to 1, and make post-renal or pre-renal until suggests that AKI reflects intrinsic injury, although confirmation of the underlying cause of intrinsic renal injury would require further evaluation. The presence of hypercalcemia provides an important diagnostic clue. Most cases with renal failure Most cases with renal failure is hypercalcemia. Sorry, most cases, okay, this point is very important. Most patient with renal failure is hypocalcemia due to reduced renal phosphate excretion. Because phosphorus combines with calcium to form calcium phosphate salt, serum salt usually decline. Patients who have acute renal failure, hypercalcemia, often have underlying malignancy that is driven by malignancy release. That is often most likely seen in multiple myeloma, which anemia, bone pain, hypercalcemia, and acute renal failure. MM-induced hypercalcemia due to osteoclast activating factors can cause AKI due to clogging of the renal tubule with calcium deposits and immunoglobulin light chain glassy light chain casts often present, but the urine analysis may be bland if cast formation has not yet occurred. Urine dipstick typically demonstrate mild proteinuria often detects albumin. However, a quantitative 24-hour protein assay will be limited. Protein excretion, Baines Jones proteinuria. Okay, I don't get it. Uh, the second para of the explanation, what they are trying to mean. Like intrinsic renal injury causing hypercalcemia. The presence of hypercalcemia is a diagnostic clue from here. Okay. Okay. Yes. Okay. Okay. Decreased cardiac output and intravascular volume depletion can cause pre-renal AKI given by creatinine more than 20, urine sodium less than 20. Hypercalcemia induced diuresis is unlikely in this case due to presence of moist membrane, which would be uncommon in the setting of significant volume depletion. And progression of diabetic nephropathy typically occurs over a period of years. This significant increase is highly unlikely to occur over 3 months. Although mild proteinuria is common, ultrasound typically demonstrates shrunken atrophic kidney and hypocalcemia, not hypercalcemia. He has problem in the kidney as well as in the liver. Looks, yes, he has cirrhosis. It's renal. It's hepatorenal syndrome. Yes, that one. Okay, evolution of AKI including evolution of AKI includes ruling out ruling out of urinary obstruction and collecting a sample of urine analysis. These patients' normal renal ultrasound exclude obstruction post-renal AKI. In these patients, normal renal ultrasound exclude obstruction post-renal AKI and and a bland urine analysis, no protein, no blood, makes intrinsic AKI unlikely. In contrast to classic prerenal AKI that resolves with volume expansion, patients with cirrhosis can develop a severe form prerenal AKI called hepatorenal syndrome. Hepatorenal syndrome is driven by neurohumoral. Hepatorenal syndrome is driven by neurohumoral cascade involving splanchnic vasodilatation that shunts blood away from the kidney, which results in severe hyperactivity of the renin-angiotensin-aldosterone system. This leads to extreme sodium reabsorption. This leads to extreme sodium reabsorption, which causes ascites that can become diuretic resistance, as in this patient. RAS hyperactivity also causes profound renal vasoconstriction that lead to progressive AKI. Due to remarkable due to the remarkable renal sodium avidity in the hepatorenal syndrome, a very low urine sodium less than 10 versus less than 20 milliequivalent per liter is a prerenal AKI is a helpful diagnostic clue. A lack of improvement with volume expansion intravenous albumin helps to confirm the diagnosis since the underlying cause is altered splanchnic and renal blood flow. Okay, yes. If you find like evolution of AKI in patient with advanced liver disease, urinary obstruction present. If urinary obstruction present, appropriate treatment. If no, collect urinalysis. Collect urinalysis. If it is bland, then bland urinalysis. It is hepato or renal syndrome suspected. If it is abnormal urinalysis or history suggestive of specific ATN, AIN, appropriate management. If bland urinalysis, hepatorenal syndrome, measure urine sodium and give a trial of volume expansion. If improvement in intravascular volume depletion, continue volume expansion if needed. If no improvement, hepatorenal syndrome, initiate splanchnic vasoconstrictor and seek for liver transplant. Okay, Okay, can we take a break like you have uh, done?